In this episode, we discuss the latest trends in clinical research, focusing on the evolving landscape of IRB oversight in 2024, including the roles of HRPP, so that's AHRP and OHRP, and the need for greater federal agency oversight. Here's what we're going to cover. IRB changes in 2024. What is an HRPP? What is AHRP? What is ORI? What is the need for federal agency involvement? What is the impact of the new guidance in the Trump administration? What is the role of OHRP and AHRP? Can the FDA actually regulate an IRB? Our guest is Edye Edens. Let's get into it. Why IRBs may be impacted, if at all, in 2024. What are the big things that have happened that impact them?
Like you said, we've had some really big things happen even in this final stretch of 24. And you and I have been making a lot of comments and talking a lot about it behind the scenes and publicly. Is, of course, the recent FDA guidance being finalized on decentralized elements in clinical trials. And what does that mean? Being able to utilize, HCPs, different modalities. What does that mean for the patient? What does that mean for clinical care providers who are in research? What does that mean for the quote unquote traditional research site or center that's not used to maybe using as many decentralized elements? What does it mean for the sponsors writing the trials and the protocols and how they're going to set that up logistically, how they're going to create that flexibility? What does it mean for the data, right? If you're collecting data different ways, if different patients are having different experiences on the trial, does that change the validity? Does that change the control? Are we on to something and maybe we just aren't circulating in the right circles? And there's two pieces to that. And one is IRBs, and two is oncology. And what I mean by those two things is what does this change, if anything, for how and what an IRB would approve? I mean, the FDA guidance doesn't come right out and tell an IRB, this is approval criteria or it's not. And the IRBs have navigated for many years now using different elements of decentralization in trials, right? Whether you want to call them hybrid, DCT, whatever you want to call it. Most of the HRPPs that I know have done this pretty darn well, given the need, the quickness, the turnaround, and the lack of regulation and guidance. So now that it's official, now what? True.
What is an HRPP? Why would people care? Most
Good
people
question.
have heard of an IRB. You talked
Right. They don't know
about,
what
for
HRPP
example,
is.
the
Yeah, yeah.
policy. So could you
Good call. Good
explain
call.
those terms?
So HRPP stands for Human Research Protection Program. And what a lot of folks don't realize is an IRB is actually a component of an HRPP. So Human Research Protection Program, the easiest example I can give you is think of a large traditional medical center that has, medical school, large hospital attached, very, traditional in the United States where we seek and find care. And in that particular environment, you have an HRPP that's going to go across all these different research compliance areas and mechanisms. Because it's not just the IRB. There's all sorts of regulations around doing research with animals. There's all sorts of, which is outside the HRPP, but connected, sorry. There's all sorts of potential for conflicts of interest regulation needs. There's all sorts of potential for quality auditing needs, whether that is, being able to actually have auditors who go out into your clinical trial community, or maybe even audit the HRPP itself, right? And be able to be prepared. You also might have research integrity and misconduct as a part of your HRPP. So there's multiple different slivers and elements and arms to a human research protection program. So your HRPP is going to be subject to the FDA if you're doing FDA regulated research. You're going to be subject to the Office for Human Research Protections.
What is AHRP and how does that fit into this? And how does ORI fit into this?
So AHRP is, and now you'll know why it's an acronym, is the Association for Accreditation of Human Research Protection Programs, which is why we need an acronym. And it's an accrediting body for human research protection programs, and it is your gold standard. If you go on to an academic medical center's IRB website or human research protection HRPP website, and it has a gold seal that says AHRP accredited, that is truly for that particular space. It's not required, but consider the gold standard for having your HRPP, inspected, audited, accredited, and adhering to the highest standards of conduct above and beyond just what's required. by the regulations. And so if you are AHRP accredited, you will then have extra standards and extra policies and extra requirements to keep that accreditation up as a part of your HRPP. And you're doing that, to be the highest standard HRPP you can be, but it's a ton of work. I mean, you're basically willfully subjecting yourself to yet another, auditor, yet another regulatory body.
So you talk about OHRP, you talk about AHRP. How does ORI fit into this, first of all?
So ORI is the Office of Research Integrity. So they're over falsification, fabrication, and plagiarism, which is what is truly known as research misconduct. We say in IRB land or HRPP land or auditing world, non-compliance, and we kind of use the word misconduct, but the true federal definition is FFP, fabrication, falsification, plagiarism. And there's more to it than that. I don't mean to simplify the regulations. It's very, intricate work, but the Office for Research Integrity is then that federal arm under DHHS that oversees any federally funded research and any allegations of misconduct. So if you're accepting federal monies, then your HRPP is going to have research integrity. You should have it anyway.
A single organization like Doge wants to do using Elon Musk, using RFK Jr. Is this what we're looking at in the future, where we're saying there's OHRP, AHRP, ORI, FDA, all overseeing clinical research? Do we need all these organizations, especially when they're all looking at just clinical research?
I mean, I have my own thoughts on Doge just from having worked in the political environment. If they were to take flight and be able to be productive, that's exactly some of the redundancy you look at, right? So Doge is coming in from the redundancy and efficiency perspective and saying, okay, I mean, yes, this is research with humans. And we do, we've really screwed it up in the past, and it has all sorts of potential safety and risk issues. We take it very seriously, but my gosh, I mean, do we really need, like you said, AHRP, OHRP, like all the acronyms? I mean, could we not make this a more efficient process? Would that not save the patient more money in the end, right? Get from the bench to the bedside faster in certain situations. And I could see, depending on how the nominations play out, certain appointees in those particular spaces going, well, we already don't trust the processes as they are. And we appreciate that you want to reduce the redundancy, but we don't think that's the answer, because we actually are suspect, even with the redundancy, that we're doing enough, right? And so then you're going to have a political nightmare on your hands from a different perspective. And I think where the industry would sit in that is, at least for most of us, and most of the folks you and I, tend to have dialogue with and work with, is we would say, please eliminate some of the redundancy. We are all for, risk-based quality management, but at the same time, there is such a thing as overkill and red tape. I mean, there is a reason that, for example, an in-house HRPP's IRB is always going to have slower turnaround times than a large commercial IRB, because they're just ensconced in more politics and bureaucracy, and it slows them down.
Given the Trump administration and Elon Musk's perspective and Vivek Ramaswamy's perspective on improving and adding efficiencies to the federal government and enhancing innovation, what is your perspective on this guidance, tying it into real world evidence, and what this all translates into with the Trump administration?
First, when you're talking about efficiency and decentralized elements in trials, I think there's been, and we saw this a lot in 2020 with the issue of decentralized trials getting tied into automatically being related to diversity, or automatically related
Right.
to, reaching more patients, or automatically was deemed patient centric. That's
Yeah.
not always necessarily the case at all.
Right.
And so I don't want us to get into, once again, saying, oh, we use decentralized elements, and so that increases efficiency or decreases efficiency, because I don't think you can blanket statement that. There's certain trials that it's just not going to make sense to do decentralized elements for. There's certain, maybe even within a trial, there might be certain visits that aren't the right fit in that particular trial. There might be, when you're talking about a phase 1 oncology study, where you have a hospital stay, you start to get into some nasty logistics in terms of being able to make that decentralized.
Before you continue, shout out to Dan Fox, who actually calls this out. he does talk about actual individual meetings, maybe decentralized, but not the study itself.
Like we were talking about earlier, when you think of Musk and Doge and what they're going to be charged to do in terms of efficiency, I definitely could understand why they would want to look at our industry and they'd want to look at these layers and layers and layers of regulatory and see if there's not, a lack of efficiency. They'd want to look at the logistics and ops. But I also think that this is still it's not a new enough concept in the sense that we haven't put it in practice. We have, but it is now officially regulated. We have opened the door toward HCP involvement and use in a new way. Even those of us within the industry are still arguing about what that looks like and what you can do with that and what you can't and where you can use it and where you can't, right? So we can't even decide. There's not enough track record to say it's efficient or it's not for a Doge like organization or agency to then come in and go, okay, we need to clean this up. We need to fix this. I don't think you have enough runway there yet. I don't think you know enough information.
What should OHRP and AHRP do in this scenario? Do they pass their own guidances in this area? Do they reconcile? Is this like a FTC FDA type of memorandum where they have to go?
So the first one is it doesn't change anything. And here's what I mean by that. Edye, we've already been approving these studies with different types of decentralized elements. Like you said, an astute point. They've been around since the 2010s. They got popular fodder in 2020 because everybody realized what was going on and the benefit they might provide in that setting. And so we actually, this isn't really new information. We've already been making these risk-based assessments and deciding what they could use. We've been doing it for years. We appreciate that the FDA brings new perspective and has opened the door. But admittedly, we don't regulate the 1572 anyway, right? So like, what do we care who's listed on it? What does that matter? How does that change our approval criteria in any way? It doesn't impact it. And so this is great. We expect to see more submissions that have HCP, utilization in them, and we'll work through those logistically with each submission as we should, but there's really nothing to change here. And I could see that being a valid point, right? Because they've already done the heavy lifting. They've already made the risk-based assessments as the years have ticked by. I could also see there being a different conversation in that we've worked so hard in HRPP world to create a sense of harmonization between the FDA and the IRB. Folks do not understand that regulatory setup. No one expects you to. It's very complicated.
You pointed out that the FDA technically does not regulate the IRBs, yet we see warning letters and we see 483s for IRBs. How does that work?
FDA can actually audit an IRB. Let's say you're an organization that does FDA regulated research, but you also do non-FDA regulated research, right? So you're a large organization and you make a determination about a study that comes through your HRPP, specifically the IRB, that it is not something that is subject to FDA regulation, right? Maybe someone wants to repurpose, reuse a test article, wants to look at something like that's already available over the counter, et cetera. And where there's a really good example of this that we see most commonly is someone wants to use something that is approved and on the market. I always use the vitamin C sepsis example that has proven in some type of an off-label setting to be very viable for a use, but has never been studied and approved. And in that moment, you have to decide as an IRB whether you're going to say, look, I need the FDA to sign off on they don't believe you need the appropriate regulatory submission, like an IND, to move forward, or they do. And so let's say your IRB decides we think you're not subject to the FDA. And then a year later, 2 years later, and while the trial is being conducted, you have an audit. Maybe it's a routine audit by the FDA. And when you're carrying a large portfolio, they're going to come look at you at the IRB. When they find that, the FDA can, in fact, actually issue a 483 to the IRB, to the HRPP, and say you did this incorrectly, or we're concerned about your policies or procedures, or we found deficiencies in how you process your submissions. Or maybe it's this very specific example. You got it wrong. You got the analysis wrong, and this should have been FDA regulated, or it shouldn't have been. Any which way, IRBs are subject to. So it's a very interesting relationship when you look at the regulations. Essentially, the FDA has the right to inspect and view. They have the right to come in and issue based on the trial and the fact that you are conducting FDA regulated research. But again, the IRB, the regulations around how you approve research and how you do your operations and what the expectations are for your performance are not established by the FDA.